Hi, I'm Sita Kedia. I'm a physician and chief medical officer for Palm Health, and today we're going to speak about menopause and the brain. So, many women, when they turn 40 or in their 40s, start to ask themselves, am I going crazy or is it just me? And they've frequently been told that this is now all a course of natural aging, just to deal with it, and it could just be stress. What women don't realize and what individuals don't realize that 40% of our life as women is spent in menopause. And up to three-fourths of those women during menopause have some type of neurological or brain symptom. So it isn't something to just deal with, it's something to actually be proactive about. And that's what we're going to be speaking about today. So we have estrogen receptors all throughout our body, not just in our ovaries, not just in our breast tissues, but everywhere in the body. And that is why we have so many different symptoms as we go into menopause and as estrogen levels start to diminish. And particularly, we have a lot of estrogen needed in our brains. And that is what is contributing to a lot of the neurological symptoms that we see. So, even though menopause is inevitable, we really like to say that suffering is not. And this is a beautiful quote by Mary Claire Haver, who helps us understand that we don't need to just deal with it. When we think about perimenopause and menopause, it's important to understand what those terms mean. So, perimenopause are the years before you have your last period. Menopause is the date of your last period. However, we don't define your last period unless you've not had your periods for more than 12 months. So it isn't until 12 months post your last period do you realize that you've actually entered into menopause. Neurological symptoms occur for years before that menopause date and into those postmenopausal years. As we really transition to understanding what our brains are doing, I want to really acknowledge that this is a beautiful transition in our life. Yes, this might be a moment of vulnerability, but this is an amazing process. And what I'm more excited about is that our medical community is actually starting to focus time and money on the scientific research and understanding of the hormonal influences that are happening during this critical time period for women. And with that knowledge, we may actually be able to empower women to do this transition gracefully and with improved health outcomes. So it is these women who are really moving the needle on this research for how our brains change in women during menopause. And a lot of what we're going to be reviewing and discussing today is the data and research produced by these three women. Lisa Mensconi, the first of those individuals, really reminded us that women have three fundamental periods in their lifetime where their brains are undergoing these developmental changes. The first transition is when girls go through puberty. And during this time, girls start to have better impulse control and this aspect of achieving theory of mind and having empathy. So, theory of mind is really putting ourselves in somebody else's shoes and really understanding somebody's perspective that's not their own. And impulse control is being able to maybe not say everything that is on our mind. The second transition happens during pregnancy. And this is where there's a large requirement of our limbic system. And our limbic system is really that emotional brain. It's what helps us really have this inherent nature to protect children and our families. It's kind of where that term of mama bear comes from. And the third transition, which is perimenopause into menopause and then postmenopause, where women really actually show increased empathy, have this sense of needing to share with the world their life experience and knowledge. And it's this notion of wise women. So, for centuries and even millennia, there is this general thought that the use of women has kind of was over once they've stopped having their period and cannot bear children. However, there's this kind of another hypothesis that has been emerging, especially as we observe hunter-gatherer societies and even killer whales. In these cases, grandmothers care for the young generations, finding them shelter and food and sharing knowledge. And this is lending to the concept that these older generations are leading to the survival of species. And I'm really encouraged by this shift in perspective that's happening at all levels of society and culture, even today, including that scientific culture in the medical communities, because we really need to put money and energy and research into the fact that women are spending 40% of their life, and we need to be thinking about their health outcomes and quality of life during this time. So funding is now being raised and being earmarked towards understanding this critical moment in a woman's health. And before we really go into some of the other things that we're going to talk about in terms of the neurological symptoms, I do want to talk about really the upside of this transition. And what we know is that studies on aging and mental health show that women often experience a renewed sense of self-assurance and psychological well-being in the postmenopausal years. And there's this shift of focus in some women who report that they're focusing more on their personal fulfillment, their self-care, their own career development, and their community engagement that's leading to general increase in life satisfaction. So what we're going to really dive into is what are we experiencing as it pertains to the neurological symptoms of perimenopause and menopause? Why do we have those symptoms? And then how do we make those transitions smoothly? We have tons of neurological symptoms that occur, and some of them are pretty obvious and some of them are well known. So cognitively, and also some of the mood symptoms that you can see listed here, from brain fog and verbal memory, word finding, even difficulty kind of multitasking, or what I like to actually call task switching, which is a whole nother conversation. And then, depression and irritability. But what I find in most individuals who've never really had mood difficulties with depression, anxiety, or irritability, that in their 40s, there's an increased kind of anxiety, general anxiety, low levels of anxiety that start to emerge. And those are the symptoms that become really prevalent and also really affect individuals, women's well-being and quality of life. Then there's this whole slew of other symptoms that you may or may not even recognize as neurological, from headaches and insomnia and sleep disturbances to really hot flashes, dizziness, decreased libido, and even decreased energy. So why do we experience these symptoms? Well, one of the studies that we've seen is these in neuroimaging studies, and you can see here, I'm going to first orient you to the slide. So here's your little marker of red is increased energy, green is kind of normal energy, and blue is low energy. And what you can see here is that we normally have in premenopausal control, so this is prior to perimenopause, these blue areas are normal areas because this is actually fluid-filled areas in our brain. But you can see the amount of redness versus in a postmenopausal woman, all this green that has emerged and kind of lower levels of energy. And you can quantify this from premenopausal to postmenopausal, that this is 30% less energy that we see in premenopausal controls compared to postmenopausal women. Then, if you have decreased energy, what else could we be experiencing that might be different in women? And that we see that we have estrogen receptors all throughout our brains. And then in key areas that give you these neurological symptoms that we experience. So we see here that we have the hippocampus. This is critical for learning, memory, and even spatial navigation. And estrogen is known to support memory formation and cognitive flexibility. We have our prefrontal cortex. This is important for our cognitive functions, our decision making, our attention, our executive control. We have our amygdala, which is processing our emotions and our fear and our anxiety. And then our hypothalamus, which is going to be affecting our temperature regulation, thirst, hunger, and then also the release of hormones. And so we can be affected by our sleep, by multiple areas in our brain, and our just general alertness. And this could be also affecting our general energy in our brain. So you can see that we have tons of estrogen receptors all throughout our brain. And these are also in our body, in our brain. And these receptors are tiny locks. And estrogen is the key. So our brains are hardwired for estrogen. So when estrogen levels drop, our body actually wants to increase the receptors that are on the cells to make them more sensitive to estrogen, giving them more chance to grab onto the small amount of estrogen that there is, so that they can effectively work. And so what we actually see in these neuroimaging studies, that if you look, this is an estrogen receptor density. So before menopause compared to after menopause, you see more estrogen receptor density. So these are the locks. Those locks have been increased because there's just not a lot of keys around, and they're trying to get as many of those estrogen keys to actually function. And so again, these are all showing that this estrogen phenomenon that's happening in our whole body is also affecting our neurological symptoms as we enter into menopause. And so I can hope you can see now through kind of the decreased energy, the estrogen in the brain, why we might experience all these different symptoms all throughout our brain, and that one can have 3/4 of women can have these neurological symptoms. One could then take a pause and say, well, if you look at any woman at any time in their lifespan, they might have any of these symptoms. And this is why it's really important to be evaluated to say, do we think that these are really related to menopause or perimenopause? Is this our best guess because of your lifespan, your life history, and your kind of medical progress over time to help us understand if estrogen is really one that's playing a part, and you entering into menopause is causing your headaches or causing your insomnia, or if it's other factors. This is why that medical evaluation is going to be important, but we have to keep it in consideration. What we've actually found is that there are a lot of positive effects of estrogen on the brain through the research that we've seen over the years emerge. That estrogen is actually neuroprotective. It increases cell growth. It helps with brain plasticity, the communication between neurons, the blood flow, and the overall energy that you see in the brain. We can't talk about menopause and estrogen without really discussing what is happening with our increased risk of Alzheimer's. And so what it's really important to know that in Alzheimer's, you have decrease in memory, you have brain fog, you have word finding difficulties, and you have difficulty in attention and concentration. These are all symptoms of Alzheimer's, but they're also symptoms that you can see just related to perimenopause and menopause. And so what is the actual association for women in Alzheimer's? And it's, in fact, being female is an independent risk factors for dementia. 2 women for every man has Alzheimer's. And it's not just about aging. So previously it was like, oh, women live longer, and that is why that we have increase in Alzheimer's, because Alzheimer's is a is a disease of aging, but in fact, we know that it's an independent risk factor despite how long somebody lives. So this is a common depiction of what I like to describe as kind of the aging process as it relates to dementia, cognitive function, and memory loss. And so if we can imagine in our 20s and our 30s, we're at our best cognitive performance, and then we might start to have some decline. And that might be in our 40s, that might be in our 50s, that might be in our 70s. And that decline is going to be different from person to person based upon their medical factors and their lifestyle factors. That is potentially normal aging. Then when you have dementia or Alzheimer's, we might be in this preclinical cognitive decline that then goes into something called mild cognitive impairment. Mild cognitive impairment is when you have cognitive symptoms and I can measure it in an exam room with cognitive testing. I can clinically see that you have cognitive symptoms that are impacting your cognitive function. Mild cognitive impairment can be the beginning of Alzheimer's. But what is difficult is that prior to this and this preclinical cognitive decline, we don't know if you're normal aging. We don't know if it's menopause or perimenopause. It could be. And we don't know if it's Alzheimer's. So it's this critical time point that we have to say there are symptoms and we should be proactive in figuring out what might be some of the factors that can help us understand what are the contributing factors of the brain fog, the memory difficulties, the even irritability and mood issues. What has been amazing is seeing the tremendous amount of shifts that we've had during these years scientifically to show that there are biological markers that we can also test that are not just based upon the exam and the cognitive testing that I do in an exam room. And so we show that we have biological markers decreasing and increasing. So what we see here is that we have decrease in glucose metabolism, we have decrease in white matter, and this is also a measure of integrity of white matter. These decrease as we go into perimenopause and then also into postmenopause. And what happens here is that we have a decrease, but we then have a concurrent compensatory mechanism of then increasing gray matter volume, increasing cerebral blood flow, trying to increase ATP production. But this red line is also showing that during these critical years, we are starting to get increased amyloid beta deposition. Amyloid beta deposition Amyloid beta is one of the proteins of the two main proteins involved in the pathology of Alzheimer's. So you can see that there's this concept of perimenopausal acceleration of amyloid beta deposition. And so this is where we have to really actually take note. And this is one of the reasons why potentially women have an increased risk of Alzheimer's that's 2 times more than their male counterparts. So I want to take kind of a pause. That can be a lot of potentially difficult to digest information about what is happening during perimenopause and menopause. And what's important to kind of think about is what is our path moving forward? Where do we go from here? And I want to stress the importance that there are a lot of things that we can do for ourselves pre-perimenopause, perimenopause, and even postmenopause to make that shift of changing the trajectory of our brain health. And that this is not a fixed phenomenon, that we have impact here. So individuals always ask me, well, what can I do for my brain health, knowing all of this? And for me, I think about it as almost a little bit of a pyramid. And a lot of individuals want to start at the very top and do the advanced technologies that are personalized to each individual. And I always say there's personalization to all these things below, and we have to have a strong foundation. And that first strong foundation is always examining and taking a moment. And I'm going to have everyone just take a minute and pause and think to themselves what provides them meaning and purpose, joy, and deep satisfaction. So I'm going to have everyone close their eyes if you haven't already. And when you think of those words, what provides me meaning, purpose, brings me joy and deep satisfaction? What images come to mind? What things or people, activities come to mind? And that is what we need to anchor ourselves on. We need to start there before we start anywhere else. And so it is with that that you can then create structure and create a plan that includes everything above it. But until we examine what truly our goals are in life, but also what is inherently giving us meaning and purpose as we make this transition, because that might be a bit different. What it is now compared to what it was 10 years ago, 20 years ago, or even 10 years from now. We also have to think about this whole pyramid of items, and we're going to go through several of these. And there's a reason that we talk about lifestyle in almost every conversation that we have. And it is because of these four fundamental things that we know move the needle on how it impacts not only our brain health, but our overall health outcome, our longevity, our health span, and our quality of life. So we're going to go through some of the reasons why these are important. So when we think about nutrition, I love to talk about this one study that shows individuals' brains when they're on a Mediterranean diet and when they're on a Western diet. And us in functional medicine like to call the Western diet the standard American diet, the SAD diet, the standard American diet. And that Western diet, compared to those who've spent their entire life on a Mediterranean diet, have increased brain volumes in numerous areas that are quantifiable in their brain. So you can see here, compared to here, you see a lot more fluid-filled areas and what we call atrophy of the brain compared to this nice meatiness of this brain. This volume is really quantifiable and has been shown that individuals on a Mediterranean lifelong diet have increased brain volumes. And the next being exercise. We have to start moving. And it is different levels of activity that are important. We know that active elderly individuals have 35% lower risk for developing dementia. 35% lower risk. That's better than any pill. We also know that there has been a strong movement to looking at cardiac or aerobic activity. But what I like to say is that it really needs to be well-rounded activity. So not only cardio, but also muscle. And so we know that muscle mass is important. And so if you're a walker, then let's start increasing our strength activities and conditioning. So you're going to add strength and conditioning. You're going to add balance and core stability. And it is really important with muscle mass. And the reason it is that not only are you protecting your joints and making sure that you're going to prevent injury, you're increasing your stability in your core, and then also you're increasing your insulin sensitivity. And so we know individuals who have increased muscle mass have better metabolic health. Their mitochondria, which is the energy source in our bodies, are increased, and we have less diabetes and improved insulin sensitivity and decreased insulin resistance. So I really like to have individuals also, if possible, do something called blood flow resistance training. So blood flow restriction training is really low intensity exercise. And this is myself with Dr. Jake Shockey, who is doing BFR training. So what this is that these are basically kind of like soft blood pressure cuffs that are put on either the legs or the arms or both. And what you're able to do is you are able to do increased muscle strength conditioning with lower weights and lower amounts of uh, of time as well. And so what you're trying to do is you're really trying to restrict the oxygen in the muscles, which then increases the skeletal blood supply and then increases delivery of growth factors to those muscles and also to the bone. It also increases the formation of bone turnover. And so you also are having this as an improvement for osteoporosis. So you can see here that you're really doing low intensity exercise, but with it feeling like you're doing high intensity training. You can do in 20 minutes what you might be doing in a normal workout with 60 minutes. You can be using about 20% or 30% of your highest weight and still get the same benefit. So there's a lot of benefits to this, and it's something that is really great for individuals who can't tolerate high weights. And it is really easy to do, and you can find trainers who are trained in this. The next is sleep. And so what we know about sleep is that there's this phenomenon called lymphatic flow. It is really important that we are all getting sleep so that we can promote lymphatic flow. All day long, we are producing metabolic waste in our bodies and in our brains. And so we have our lymphatic system that's constantly pumping our toxins out and into our bloodstream that can be then flushed out through our kidneys. But in our brains, some of that is happening during waking hours, but the majority of that is happening during sleep and during different phases of sleep. So it's really important that we get to sleep and that we really get into the different stages of sleep, particularly deep sleep. And this is happening at a much higher rate during deep sleep. And what's actually happening is that there's studies that show that the brain waves that are produced, alpha, beta, delta, and theta, are actually helping almost nearly pump the metabolic waste out of our brains and into our lymphatic system to be cleared out. And so what is happening is that we're constantly producing amyloid beta in our brains. Everyone, whether you are 20 or 30 years old, or whether you're 70 or 80, they're just at different rates. And our brain during sleep is what's clearing those amyloid beta plaques out and the tau proteins. And so if we can do that during sleep with good sleep throughout the day, during the good sleep throughout the night, we can do this well. So that's one of the reasons. There's a lot of reasons why sleep is important. This is one of the primary reasons. So this is a good moment when we're talking about sleep. There's lots of sleep hygiene things that you should be doing. But also we have our micronutrients that we can be thinking about. So magnesium is one of them that I really particularly am fond of for sleep. And so magnesium is interesting. There's lots of different forms of magnesium. When you go to the grocery store and you're looking at the shelves of all the different magnesium, there's lots of them. And magnesium can help with constipation. It can help with muscle recovery. It can help with relaxation and general anxiety, and it can help with sleep. And there's different forms of magnesium. And so I particularly like the ones that are chelated with magnesium glycinate and magnesium threonate. Those are particularly good for the brain and good for sleep. And they're really good for just the brain and cognitive health in general. So it's really important to do B vitamins, especially if you don't think that you're getting it through your own natural foods. I always say food is your first place to start. It's the most bioavailable. But then some individuals might need to actually, because we just can't keep up with the amount of vitamins and minerals we need. The third essential micronutrient that I think that we need for our brain health are omega-3 fatty acids. There's two different types of omega-3 fatty acids. One is EPA and the other one is DHA. They're both good for the brain. EPA is more anti-inflammatory and also good for your cardiovascular health and your overall health. And DHA is particularly helpful for the brain. And so I really like to make sure that everyone's looking at the back of the bottles and looking for good sources of EPA and DHA, but also good quantities of it. And finding good blends that are not only just having EPA, but also the DHA with it. And then lastly, you can't have a conversation about micronutrients and vitamins without talking about vitamin D. It's really important to really at least have a baseline measurement of where your vitamin D is. And we really like vitamin D levels to be around 50 to 80. And so get your vitamin D checked. If it's above 30, that's good, but we really want it above 50 and really getting at least 2,000 units, but really working with a physician and a medical provider to help you know what type of vitamin D, because we also like it to be with K2 and also like to have it at a good dose that's not going to be too much or too toxic or even kidney stone producing, and also not too low. So work with your healthcare practitioner to help you find the best balance of supplements for you if you do need a supplement beyond your nutritional intake. So methylene blue is another thing that has been really a lot in the news about its potential effect on cognition. I like to mention it just because there's a lot of information that is emerging. The verdict is still fully out on the effects of it for Alzheimer's or dementia, but there seems to be some improvement in just general brain function, attention, concentration, as well as mood. So we can't do a conversation about menopause in the brain without talking about hormone replacement therapy. And this is a really complicated conversation. And what I think is really important to know is that we were practicing a whole different way before 2000 on what do we do for women on hormone replacement therapy. In 2002, there was a really large study that came out that indicated that hormone replacement therapy might actually be harming us by increasing cardiovascular risk as well as other outcomes, including memory and dementia. What then happened was, because of this, everyone was taken off of hormone replacement therapy. And then individuals, scientists, started to kind of pick the information. And what we found out was there's a lot of conclusions made that weren't really necessarily applicable to what women and doctors were actually doing. So, one is that the hormones that were being given are different than the hormones that we know to be better for a woman's body. So they were synthetic, They might have had multiple different types of estrogen, whereas the bioidentical estrogens that we now use for hormone replacement are very bioidentical. They are kind of what our women actually naturally produce, specifically estradiol. The second is that the women that they studied, the large majority of them started hormone replacement therapy years, 10 years plus after menopause. And when they actually teased apart women who received hormone replacement therapy at the time of menopause, as opposed to 10, 15 years post menopause, there was actually distinct differences in those groups and those health outcomes. And that there is actually more knowledge emerging that if we were to start hormone replacement therapy during this critical time window of perimenopause and menopause, and even up to 10 years post-menopause, we actually might have protective health outcomes with hormone replacement therapy, as opposed to women who are started on hormone replacement therapy 10 or 15 years later. And so there's this critical time window during this that we should be thinking about as it is beneficial to brain health. And at the end of the day, it is really a personal decision between you and your medical provider that helps you determine whether hormone replacement therapy is actually beneficial for you. Hormone replacement therapy for certain indications of symptoms, as well as osteoporosis, is indicated for women. And so we have to really weigh your past medical history, your own personal cancer risks, as well as your family history of cancer. You may also even consider your dementia risks and really known. There are different programs that we have if you're really interested in memory. These are called Precode and Recode, and this is really using the framework that Dr. Dale Bredesen uses for dementia, memory loss, and really all neurological disease as one ages. And that is something that we offer and can be beneficial. And I always like to kind of end and remember that we as women have kind of stopped talking about our symptoms of menopause because we really kind of were quieted in the 2000s and the 2010s. And now it's our time to kind of gather amongst our families and our friends and our social support and the women around us to help us understand ourselves and to get help. And it is our moment to do that with our brain and through menopause. So I hope this was really helpful for you, thinking about how menopause might be affecting you, how these symptoms may be related to perimenopause, and giving you a little bit of a framework that there are things that you can do right now. Thank you so much, and I appreciate your time.